Welcome to Own Your Heart Health. I'm Dr. Regina Druz, your holistic cardiologist. This week, we will dive into common heart health concerns, uncovering root causes, and unpacking scientific discoveries and controversies. The information provided does not constitute medical advice. Please contact your healthcare practitioner before making any changes that may impact your health. Hi, everyone. This is another Friday fun day. And I'm super excited today because I finally got a chance to bring on a guest speaker who is an absolute expert in one of the most difficult and controversial areas of cardiology. Yes, today we're going to be talking about a little lipoprotein particle that causes a lot of trouble. And you may have had its name before. It's called lipoprotein little a. And so the expert today for us is my colleague and local Long Islander, Dr. Guy Mintz. Now, let me tell you about Dr. Mintz. Dr. Mintz, of course, is a cardiologist, but he's actually a director for cardiovascular health and lipidology, as well as an apheresis program for Northwell Health System. And he has been instrumental in creating a center for advanced lipid disorders in our area, one of the few regional centers of excellence. And in addition to all of this, Dr. Guy Mintz is just a great guy. You know, he loves patients. He loves to speak with his colleagues. And so welcome to the show, Guy.
Thank you, Regina. Thank you for giving me the opportunity to speak with the public and, bring the words of prevention to everyone.
There you go. And so I'm going to ask you a question that I ask all of my guests, which is, how did you grow up to be, and in your case, a lipidologist? So how did you grow up to be a lipidologist? Because I remember, you and I are both sort of not newbies in cardiology. And when we were starting, there really wasn't such a thing, a whole lot as lipidology.
Yeah, I think that's a great question because we're very good at treating heart disease. So if there's a 90% blockage, we'll put a stent in and we look like heroes, or we'll, do coronary artery bypass surgery and we look like heroes. But the problem really is atherosclerosis is a disease. It affects the entire vascular tree and not just within the heart. We're talking about the peripheral arteries. We're talking about the blood vessels to the brain. So it's a true disease. It's not a one-stop shop, get a stent and you're fixed, because the reality is, even if you look at cause of heart attack, the most common blockage causing a heart attack is a 50% obstruction, plaque rupture, myocardial infarction. So 50% obstruction is something the interventional cardiologists wouldn't touch. So we go back to the primary cardiologist and say medical therapy and risk factor management. So, what really interests me is, well, as I said, we're good at fixing the end result, but where are we from the beginning? And I think having an opportunity to affect the patient's life, quality of life and disease state throughout a lifetime is challenging and a very important mission. So that's kind of where I focused on how do we prevent this in the beginning, and in another way, lightheartedly, put the interventional cardiologists and surgeons out of business. So that's our challenge.
Your challenge. So, it is so great that you're actually bringing this up, because as we see patients, you and I are both clinicians, right? So we see patients, and very often patients come in and they say, well, I had a cardiac cath or I had a CT angio, and there wasn't really, I was told everything is fine. And I would say, well, show me your report. And you would see, for example, I just saw a patient like this yesterday where indeed there were no lesions that should be stented, right? But there was diffuse disease in all three coronary artery beds. And that diffuse disease is a marker of a very aggressive atherosclerosis for this patient. This is a high-risk patient, despite the fact that they're lacking, for example, a specific focal area that could be stented. So tell us a little bit about, let's talk about the culprit and the subject of today's episode, lipoprotein little a. What is it, and why should people care about it?
So it's a great question. There was an editorial or an article in the Times maybe 15 or 20 years ago, and it was titled Lipoprotein A, the risk factor doctors or cardiologists don't know about. So it becomes very interesting. And, let's just take it to another level. My middle name could be Plaque Attack. So how do we do that? So we're very good at saying, let's reduce the cholesterol. Let's do this. Let's do that. But the best cholesterol lowering drugs will lower cardiac events, maybe 50%. So what makes up the other 40%? So it opens up an entire discussion of what's called residual risk. What else is involved there? So lipoprotein A is a molecule. It's like an LDL, a bad cholesterol molecule, with an A attached to it and an ApoB. And what it's associated with is early heart attack, stroke, aortic stenosis, valvular stenosis at an earlier age, peripheral arterial disease, aortic aneurysms, and progression of atherosclerosis throughout the body, basically through an inflammatory effect. So once we lower your cholesterol, the job's not over. The job is what else is contributing to the risk that's going to cause cardiovascular disease.
Hi, everyone. It's Dr. Regina here. I know there are contradictory opinions about nutrition for heart health and longevity. Discussion often gets heated and confusing. There are those who push for low fat, low cholesterol. Then there are fans of a ketogenic diet. There are many anti-meat voices as well, suggesting vegan or vegetarian style of eating. With all the chatter out there on what and how to eat, my team and I decided to create a tool for patients, medical professionals to clear the clutter. It is called Holistic Heart University, and it provides on-demand courses, nutrition and lifestyle resources, information on supplements to make it easier to understand how to make healthy choices for your heart. I'm especially proud of our open office hours for program patients and the Q&A feature where you get to ask your individual questions and put us in the hot seat. Head out to the show notes for the link and use my special promo code to get a huge 20% off on our annual health and wellness subscription. The code is OWNER20, and I'll see you in the office hours. So what is that little A attached to the lipoprotein little a? What exactly is the A? I'm sure a lot of our listeners have this issue because, the public is bombarded with a lot of abbreviations, right? People probably know about ApoB, but what is a little A and how that factors in?
So, it's an A protein that gets packaged, if you will, and you have this, molecule of, your bad cholesterol, your LDL. There's a B tattoo on everything. And then there's the A added onto it. And it's consisted of, these Kringle units. And I tell my patients, not Pringle, don't eat it, but Kringle. And these Kringles are isoforms, and it's Kringle 4 type 2. And they vary in number. They're different isoforms of it, not to get too technical. And it almost, looks like a snake wrapped around of many of these Kringle units, which repeat themselves. And, you can have large isoforms and you can have small isoforms of this lipoprotein A out there. And again, it's not something that we test for, in the offices, but, what it is, it's something that, is associated, as I said, with increased cardiovascular risk. So if you have a lot of these isoforms, you can be associated with lower LPA. And if you have fewer isoforms or fewer repeating units, then you can have a higher lipoprotein A. So we get this question sometimes too. And lipoprotein A is tested with a simple blood test. So when you go to your doctor and you get your physical and they say, oh, we're going to check your lipid panel, they can add the lipoprotein A to it. It's not dependent on fasting. It's kind of like your personal tattoo, if you will. Mm-hmm. And it's measured with the usual lipid unit. And then sometimes it'll be repeated, whether the primary doctor does it or cardiologist down the road, and the numbers are not totally the same. And the reason can be dependent on the isoform and also the way we test it with antibodies and reagents. May not be totally exact, so it may not pick up, the entire isoform or the entire LPA molecule or part of it. But either way, having a high lipoprotein A is a cardiovascular risk enhancing feature.
Interesting. So let me maybe broaden our scope a little bit in case this is the first time. Some listeners may be encountering this terminology for the first time. So we need to backtrack slightly. So, lipoprotein little a is still an ApoB containing particle, right? It's one of the ApoB containing particles. So most, I think, listeners have heard about ApoB, and they understand that cholesterol just doesn't circulate in the blood as a lump of, lipid. It is protected by the proteins. We call them apolipoproteins because this is how actually cholesterol is being shuttled in the body. There is a cholesterol transport. And by the way, there is an episode that I did called Cholesterol Marbles. So if you're new to this podcast or the show, do take a look at cholesterol marbles so that you can understand, I illustrated this concept, using marbles. But so lipoprotein little a has a very specific coating of protein on it. And this is where those Kringle repeats actually come into play. And my understanding is the Kringle is some type of a donut or a pastry. I think, the discoverers of lipoprotein little a felt that these folds in the protein were perhaps reminiscent of a pastry. It's a Danish pastry, which is very popular. It's called Kringle. And so they call these things Kringle repeats. So this is how people can remember it. And so you mentioned the isoforms. And my understanding is that depending on this number of Kringle repeats, people either have small particles of lipoprotein little a or larger particles, right? Those what those isoforms are. So what is more dangerous, having smaller kind of particles or having larger particles? Is there any knowledge on that?
Well, the smaller isoforms are associated with higher levels of lipoprotein A, and they are associated with coronary disease, as I said, aortic valve disease, peripheral arterial disease, and smoke and progressive atherosclerosis. So, yeah, small isoforms, higher lipoprotein A. There's an inverse relationship there.
Interesting.
And, I like the historical piece that you give. So just like you shouldn't, eat your, Pringles, you probably shouldn't be in the Danish pastry shop to have Pringles either. But
Right. So
they're they're not from eating Pringles. They're
they're
just
not from eating Kringles for sure. And so this also brings up another point is that a lot of the damage, as you said, the damage is proportional to the level of lipoprotein little a that is detectable on the blood test. And, there are patients who have levels which are within normal range. And certainly there are patients whose levels are very high. And so I think these large isoforms usually get cleared faster. That's my understanding. And that's why they're perhaps less damaging than these small isoforms. I remember my first lipoprotein little a patient presented, and the reason that I thought she may be having this issue is that she presented actually with central retinal artery occlusion, right? Amaurosis pubis. She was a cardiac patient in her 60s, very healthy lifestyle, and seemed to have a lot of coronary artery disease. And this was her presentation. And this sort of was the first time that I began to focus on lipoprotein little a. But Guy, there is a lot of in the laboratory reports, and patients also know this, and physicians also know this. We are stating in many regards that lipoprotein little a levels are genetic. So, is this true for most patients? And if, how is there, are there specific types of lipoprotein A genes that a person should be concerned about? Should a person with elevated lipoprotein little a just assume it is genetic, or should they actually request genetic testing?
Okay, I think that's a great question. So, 1 in 5 people have an elevated lipoprotein A to some degree. We could talk about, a degree later as we tie this into a more patient-centric discussion. But 90% of elevated lipoprotein A levels are determined by genetic variation on the LPA gene, which is chromosome number 6.
Mm-hmm.
So it's, highly inheritable. It's passed on actually as an autosomal codominant, also affected by multiple genetic factors. And again, it's based on the number of the Kringled 2-unit repeats. which in and of itself, as we've discussed, could be, highly polymorphic, composed of many things. And within that, certain genes can have variants as well. So there are single nucleotide polymorphisms in there in the LPA gene, which also can affect the LPA levels. So there's clearly a genetic, component to it. We'll do in our practice genetic testing for cardiovascular disease. We'll look at the, 4 major LDL receptor mutations and some other things. I don't know if you're doing any other advanced genetic testing along the LPA levels, but, let me know. But, so there's genetics. So I tell patients, your LPA is not elevated from eating poorly or not exercising enough. We need you to do all that stuff to negate the other risk factors that contribute to cardiovascular disease. But it's a genetic tattoo that patients have that are passed on. So the other point to make along the genetic aspect is if someone has an elevated lipoprotein A, they should have first-degree relative cascade screening. Mm-hmm. So brothers, sisters, parents, children, etc., should all be tested, all first-degree relatives.
I agree. And, we pretty much do genetic testing for, I'm going to say 99% of our patients. And actually, we have something called Hartwell Toolkit, which is home-based genetic testing and laboratory testing that a person could get through holistic heart centers if they have, unable to obtain this through their physician. And I've been surprised how difficult it is actually to get genetic testing at a reasonable price point. And this is why the Hartwell Toolkit was built. But in addition to genotyping, which is what looks like you're doing a lot of it, we also do polygenic risk scoring. So polygenic risk scoring obviously has additional value because it allows smaller variants, although, LPA gene variants are pretty massive with regard to their effect size, but it allows smaller variants in all of the lipid pathways to be scored, so to speak, versus a reference population. So I find that this is tremendously helpful because when patients are struggling, for example, should they take a drug? Should they, use a statin? Should they use something else? How much impact will diet, exercise, and supplements have? We actually have the answer. And it's so true that, LP(a) is not really influenced much by anything. Yes, healthy diet, exercise are important. I had patients use, vitamin C, niacin, bioidentical hormones seem to play a role, but nothing is really lowering it sustainably. However, doing genetic testing, I observed 2 patterns. They're minor patterns, and I wonder if you had seen it and could comment on it. So there are a few patients who have high lipoprotein a, beyond the cutoff, depending on the units. And then we're going to talk about that there are 2 types of units, which makes things very confusing. But there are patients who have elevated lipoprotein a, and yet on genetic testing, there are no variants uncovered, both in terms of just SNPs, the genotyping, or even polygenic scores. And then there are patients who do have a genetic variant, yet lipoprotein a level is normal. So how do we think about this in the context of what we've discussed?
Well, I think that's a great question. And we do see that incongruities as well. And, basically it could be due to lipoprotein A plasma concentration different. The ApoA isoform size could be variable. And as we said, there are definitely polygene effects as well, contributing to some of the variants there. So I think you have to look at the patient holistically because, not every test is going to address everything very nicely in a package with a bow. So I think you look at the entire patient, look at their overall risk, look where the number could be. We talked about they might have, larger isoforms and lower LPA and smaller isoforms and larger LPA. So it's not enough to walk away from everything and be satisfied. I think, we look at levels of high sensitivity C-reactive protein, inflammation, other things, that play a role there to help guide us. We do look, you mentioned earlier, at ApoB levels, which is on every atherogenic particle. So you're looking to make an entire story, not base it on, one genetic test, which may be incongruent to what you think.
Right. And
So
so
we
this
definitely.
is, yeah, this is very interesting because I had seen it. I'm going to say maybe 10% of all patients who go through genetic testing through us, we had seen this occur, and it has a couple of phenotypes because I can tell you just anecdotally, and I hadn't really, looked at the numbers specifically, but middle-aged women, especially perimenopause and menopause, seem to have this issue where there is discordance between genetic result and the lipoprotein little a concentration. So with regards to, I'm assuming that, some people who are listening to us may have never had it measured. Some people could have already had it measured. Can you tell us about, first of all, the units of lipoprotein little a and kind of the levels of risk, right? Because there is a division in a level of risk. And what is the current thinking with regard to repeat measurements?
Okay, that's a great question. I just want to go back to one thing you just mentioned. And, as women get older in their postmenopause, the LPA levels, can increase. And women in general may have a slightly lower LPA level than men, but still, you have to look at everything, holistically, as we said. And, certainly you could talk about, how to look at the LP levels in menopause as, they may increase as estrogen, levels decline. But in
Yes,
answer
I
to your
had seen that
question,
too.
yeah. So, and again, that's why it's very important. And I know you do it all the time. You look at the patient as an individual. Where are they coming to me from? What is their family history? What is their risk? Where are they in their, life, cycle, so to speak? And that's important. And, many times physicians don't have the time, to look at the patient holistically, and getting everything done. So I think that becomes very important. And, something, people should emulate, what you do and, what I do and looking at these patients. So patients, go to different laboratories, they go to, different doctors, and the lipoprotein A levels can be measured in, different units. So we, like the concentration, which is in nanomoles per liter, as opposed to in mass, which is milligrams per deciliter. And we just highlighted earlier how the levels of the lipoprotein A can vary, be variable based on the isoform. So the mass can change based on the number of Pringles and, wraparounds, so to speak.
Mm-hmm.
So the world is going to more focus on concentration, which is nanomoles per liter. But, as we like to say, any measurement of LPA is a good measurement of LPA. So we rather you measure it in whatever your laboratory could do it in to give us an ideal risk for the patient than just not do it at all.
Right.
So,
So it's interesting because I also, like, a couple of times we had situations where patients had results from different labs and they couldn't reconcile the numbers, but that's because the units were different. So in nanomoles per liter, the concentration, what is considered currently a level that portends high risk for a patient?
right. So again, and I get consults, same as you. Patients come all over and they say, "Oh, doc, my LPA is good. It's 60 milligrams per deciliter, but that's high risk." And the
Right.
doc looks at it quickly and says, "Yeah, it's 60." So in getting to where you are, uh, we measured in nanomoles per liter. Less than 75 nanomoles per liter is low risk. Intermediate risk is 75 nanomoles per liter up to 125. And when the LPA is 125 nanomoles per liter or greater, it's higher risk.
Mm-hmm.
So I see patients. I saw someone the other day, their LPA was 100. They were young. There were no other risk factors. And I explained to them it's one risk enhancing feature. It doesn't mean game over and, we can't do anything. So I think, using The guideline of less than 75, 75 to 125, and greater than 125 is a high risk, really can, identify your patients that you're seeing on a base-to-base basis. And, the National Lipid Association came out with that kind of algorithm of 75, which we know is normal, low risk, and then greater than 125, higher risk.
Hi, everyone. It's Dr. Regina here. Many of my colleagues and I are noticing patients coming to us with self-ordered blood tests. When this trend started to gain momentum, I thought it would benefit many patients. After all, who doesn't want more access to health testing? However, I see that self-ordered labs often lead to more confusion and frustration for our patients. Patients are coming in with a pile of labs, and sadly, they're not better off for it. This is why we at Holistic Heart Centers have launched Heartwell Toolkits, a curated collection of blood and genetic markers that one can get at home, focused on heart and brain health, gives you all the data you need to make informed and actionable health decisions. The toolkits can be ordered at our shop on holisticheartcenters.com. You can find the link in the show notes. Use the code TESTING10 to get 10% off and free shipping. One of the things that is challenging, and I think you mentioned it, is that traditional guidelines currently recognize lipoprotein(a) as a risk enhancer, right? So it's really, and there are other risk enhancers too, but there is no calculation, sort of like no rule of thumb that spits out a number of a 10-year risk of cardiovascular events that includes lipoprotein(a) into the calculation. At least I'm not aware of any such calculators. There could be some that I'm just not aware of. And that's despite the fact that there was a very recent study from UK Biobank that showed how impactful lipoprotein(a) is with the independent risk increase on top of all the ApoB particles of close to 20%. So I'm wondering, since you are very much involved with National Lipid Association and we're part of their guidelines, a kind of advisory to physicians on lipoprotein(a), where is the sort of pendulum is swinging? Are the professional organizations going to push for inclusion of lipoprotein(a) in standard lipid panels? Because right now it's not happening.
Right. No, that's certainly another great question, and I think you also highlighted something else. So, getting to even measuring, who gets measured of lipoprotein(a), as we said, it's a risk enhancing feature. It means that it's another risk factor. So the American Heart Association, American College of Cardiology consider risk enhancing feature and take it into consideration. The European Atherosclerosis Society says it's definitely a risk factor and should be measured once in every adult in their lifetime, at least once. And the National Lipid Association also feels the same way, that LPA should be measured at least once in an adult in their lifetime. So I think in terms of how to move this to a standard lipid panel, you have two challenges there. One, we need to educate physicians. We need to educate, all clinicians, and ACPs, et cetera, of the risk associated with it. And then the next piece of the puzzle is, from an economic standpoint, if it's in the standard lipid panel and everybody's ordering lipid panels to follow LDL, they're going to get a lot of LPA, and a lot of insurance companies, may only cover it once in a lifetime. Mm-hmm. And even though it's say, less than $50 a test, they charge you 4 times that in some laboratories. So I think the inertia is really to put it as an add-on to the lipid panel, which is what you do and I do in our offices in terms of, looking at risk. But certainly it should be evaluated, in my opinion, like the National Lipid Association, in every adult, at least once.
And I think it's super important. And also what you mentioned earlier, testing first degree relatives, right? The cascade screening, because I just saw a patient who's young, 29 years old, really in great shape, fantastic shape, who one of patient's parents is the genetic carrier. And of course, this patient unfortunately is a genetic carrier as well, but then has a lot of other, pathways with genetic variability in lipid and metabolic pathways that even further increase their risk. So it's always a combination, and I think a lot of it depends on how prepared a healthcare professional or physician is in interpreting these findings. So what is your strategy? Let's say when you mentioned young patient, I mentioned young patients. What do you do for them? Do you give them aspirin? Do you put them on a statin? Those sort of are typical things that guidelines advise. What is your approach to patients with lipoprotein literate levels and that high risk, provided that they are from other parameters are potentially in a low risk category, right? So there's sort of a discordance that traditional risk factors map them out as low, but this risk enhancing feature is so powerful, it kind of catapults them in the entirely different risk category. So how do you reconcile this?
Well, one is through education, and you need to spend time with your patients to educate them and explain, where the risk is coming from. As I said earlier, we're all in love with lowering the bad cholesterol, but that's 50% of the job. The job's not over at that point. So once you recognize there are other factors that contribute to progression of disease, then you basically, will sit down with them and say, where are we today? And if we measure the lipoprotein A and it's elevated, again, the group with 125 or greater, we put it into context. What are their other risk factors? Like I'm talking about the patient I saw with the 105, whatever the LPA was, there was a young adult with no other risk factors. So we encourage healthy diet, exercise, manage perfect weight and so on and so forth. But now if you're telling me we have someone with increased risk, they have hypertension, they have diabetes, then we respect LP little a. You hit on the UK biobank studies, which show there's a direct relationship to
Mhm.
LPA and myocardial infarction, LPA and coronary disease, and the other vascular beds. Direct relation, meaning is one increases it, so does the risk of a clinical event. And in the Copenhagen general population study, same thing, higher LPA, greater myocardial infarction. So, the answer is, currently in the year 2025, we don't have a specific therapy for LPA. So once we decide we're going to have to lower their risk, overall cardiovascular risk with regard to LP little a, we attack the LDL cholesterol, right? So, we want to lower LDL, reduce their risk as low as we can, lower it based on our guidelines. And then depending on where we are with the patient, if it's a high risk patient with coronary disease, medications that we use, such as PCSK9 injectables or another injectable called inclisiran, which is a small interfering RNA molecule, they can lower LPA as a side benefit of 20 to 30%. They're not indicated for that, but if you find a high risk patient, now this is someone with disease that needs greater LDL lowering, and they have high LPA, you get a two in one benefit there. In terms of where we start, we lower the LDL because LDL is clearly a specific risk factor for coronary disease. And then we'll look at other things as well. But healthy lifestyle, proper diet, proper weight, proper exercise, and then we start with statin therapy.
But statin therapy, so it's interesting because that's where you and I are divergent, in some ways, not in all ways, but in some ways. Because sometimes, I think up to 20% of the time, statins may actually bump up lipoprotein literally level. And I also have not seen a universal lowering response with PCSK9s because sometimes, a patient is injected with PCSK9s and does not seem to affect lipoprotein literally level much. Specifically, I had seen it in genetic carriers. So what we try to do is that we try to go one step further because we try to assess, has there been or what has been a vascular impact of this lipoprotein little a elevation. So in some patients, we'll get a coronary calcium score, although I'm aware that there is no direct relationship within lipoprotein lily and CAC. But we actually do a lot of carotid intermediate thickness measurements and, trying to establish person's vascular age and follow it over time. So it's kind of a combination. Now, these newer drugs that we're all waiting for, right, that's supposed to be lipoprotein little a specific. Can you tell us about what they are and what had been seen so far in the studies, and what is the timeline? Because I have advised some of my patients to connect with the research sites at large universities that are offering, enrollment into the phase 3 trials. So what is your take on this?
Right. Well, I think, currently, and we can talk a little more about it, currently the only FDA approved treatment for elevated lipoprotein A is lipoprotein apheresis. And we could talk a little more about that and what that is. I like what you're doing in terms of looking for impact of LPA, because you're looking for, cardiovascular effects and, for the audience, intimal change in carotid intimal medial thickness is the very beginning of, endothelial, the inside of the vessel changes. Carotid arteries are very big vessels, and, for them to get plaque, they've already missed the boat. So looking for early impact is important. And, calcium score, starting to see calcium in the walls of the vessels of the heart, certainly important as well. So, what you're doing is, assessing, cardiovascular risk. And you're right, statins, can increase the levels of LPA. And I give a horrible non-medical physiologic analysis of the statin effect. So please don't bore me from reality after this. But I tell patients, if we put you on, high dose statin therapy to reduce your cardiovascular risk, and statins do, more than lowering LDL cholesterol. They are anti-inflammatory. They have anti-proliferative effects. So there are other benefits, along lines. But I'll tell patients, it's like going to a dance. If I lower the LDL, the lipoprotein A has nothing to attach to. So it's like they're sitting on the side waiting for a dance partner. So the levels of LPA could be higher, but they're not attaching to the LDL. So I'm waiting for the ceiling to drop on my head right now. So totally physiologically incorrect, but patients can understand that, because if they do happen to measure an LPA after high dose statin therapy, it may actually increase. Yeah. So, you kind of have to, get patients, as you say, you have to have a nice discussion with them. I like to tell them we need to all row in the same direction, because if we're not rowing in the same direction, the boat spins around in a circle. So, we'll talk about lipoprotein apheresis in a little bit, because I want to put that in the context of having a great respect for lipoprotein A. But in answer to your question, so very exciting stuff. There are many drugs being developed that have shown efficacy, meaning we can lower LPA over 90%, in different formats. The closest to a rival for us is a medicine called pelacarsen, which is an antisense oligonucleotide, which can reduce LPA, 80 to 90%, plus, and talking about dosing once a month. So that's the closest to us. They've completed their trials, which showed safety and efficacy works. What's being completed now is, does that translate into reduction in cardiovascular events, reduction in heart attack, stroke, peripheral arterial disease? So that's coming, and probably the drugs will not be available to us till maybe the first quarter of 27. That's kind of right here. So if we're lucky, it might be the end of 26, but we'll see. So pelacarsen's a once a month injection, and that's the first one. The next one right behind it is called olpasiran, which is a small interfering RNA molecule. So, medicine's changing. We always talked about precision medicine. Now cardiology has precision medicine. So what this small interfering RNA molecule does, it gets into the cell and says, we're going to go to the RNA, which codes for production of the protein, and we're going to not let the protein be produced, because we're going to interfere with the RNA. So these small interfering RNA molecules, and we're using one now in terms of lowering LDL cholesterol called inclisiran, are very effective. So lopasiran is a medication that's been shown to reduce LPA 90 to 95%. And that's being studied. So again, the results on that study are expected at the end of 26. So again, as I tell you, probably, in 27. And then there are small interfering RNA molecules, which are silencing molecules. And then the one that patients ask me about because it caught the newspapers is a medicine called lipodicirin, which is another small interfering RNA molecule.
Good name, though, lipodicirin. That's probably why it caught the newspapers.
Right, exactly. Lower LPA greater than 94, 95%, but maybe you can give it every 6 months.
Interesting.
So, like anything else in the supermarket, there'll be different styles and different, formulation and different frequencies. So I think for the patients that are, needing therapy, you're talking about 2027. So just keep your eyes open.
Sure.
A lot of the studies have closed in terms of recruitment. Different sites may have some openings. But very impressive. As I said, they've shown to be safe and very effective in accomplishing the mission of lowering the LPA. So that'll be, a nice therapy to add to our toolbox. So we're excited about that. And then, of course, as I said, currently, lipoprotein apheresis. And I don't know if you want to talk about that now.
I would love for you to talk about that. I would love for you to tell people what apheresis actually is, how it is, how it works, how it benefits patients, and what a patient experience going through apheresis actually is like.
Terrific. So, so what it is, very simply, is filtering of the blood. Now, this is not dialysis. It's not really a lot of wear and tear on the patient. It's through the veins. So we basically take blood and we have to put in, for patient comfort and convenience, we put in 2 subcutaneous ports, almost like chemotherapy ports. We pull the blood out, we filter the blood, and we take out all the positively charged apoproteins, which are, there. And that includes lipoprotein A, lipoprotein B, lipoprotein B, LDL. So we filter all of that out, and then we warm the blood and return it back. So acutely, we're lowering the LPA 70%, with the treatment. The treatment takes about 2.5 hours. Some people, we go a little slower, 2 hours, 45 minutes. The patient's sitting in the chair, they're on their computer, they're talking on the phone, there's no wear and tear. And basically, you get immediate results, meaning the patient's cholesterol is filtered into a bag, and they're sitting there seeing this bag fill up with yellow material. That's all their, bad lipoproteins.
So they're actually watching it.
Correct. And then, in terms of frequency, it's every 2 weeks for most patients. So these include patients with familial hypercholesterolemia. Patients with lipoprotein A could be 1 to 2 weeks. And, what happens with lipoprotein A, you could filter it out. And then, within 1 day, it's starting to climb again. And then it needs to, get filtered out again. So, what I've seen in patients referred to me, and this is, really, I have great respect for lipoprotein A. Patients come to me, their LDL is 25 and they are closing their stents. They're getting peripheral arterial disease. One patient that was referred to me from the city had an LDL of 22 and closed his stents in his, right lower extremity. And I had a patient waiting for apheresis. Wow. And he had to have bypass despite LDLs of 35. So, again, and we'll talk a little bit more about why LPA is a culprit in a lot of this, due to its inflammatory effect. But so here you have people that are very well managed. They come to me, but doc, they're still having events. What am I going to do? Their LPA is 180. Their LPA is 200. Their LPI patients with LPAs of 500. And again, so the only, indication or treatment is apheresis. So the official indication is clinical familial hypercholesterolemia. So they like you to have, high cholesterol. You need to have an LPA of greater than 60 milligrams per deciliter. So there you go, Regina, with the,
That's the mass
RPA,
measurement, as we learned.
right? JFK has not gotten over there to convert it to nanomoles per liter yet. So remember,
You mean
it's 60.
RFK? RFK is
RPA, right? I'm sorry, right?
it has not converted it yet. Okay.
I didn't have my coffee yet. It's okay. So we have 60 milligrams per deciliter, which is about 130 nanomoles per liter or greater. And we need peripheral arterial disease and coronary artery disease. So again, you need clinical familial hypercholesterolemia. Clinical, you don't need genetic testing. You need disease, coronary disease, peripheral arterial disease, and an LPA of 60 milligrams per deciliter or greater. That's a change that came in 2025. What was prior to 2025, it was you needed an LDL of greater than 100. They dropped the LDL.
They dropped the LDL requirement.
And the most lipid apheresis in the world is in Germany. So in Germany, is number one. You have Europe as well. All you need is, again, CAD, PAD, clinical FH, and a high LPA, and, you're going. So we adapted that with the FDA here to use that indication. So it's not like some mysterious treatment. It's very well tolerated. Patients are very grateful because, they're getting, effective treatment, not only for the LDL cholesterol, but for the lipoprotein A. So until we have these amazing, drugs in the end of 26 or 27, that's the only game in town now. Of course, you have to have, insurance approval for it, but very effective. And then currently there are only 2 centers in New York State that does lipoprotein apheresis. So one is Northwell here in our center, and the other is Cornell in the city, which does a lot of children.
Interesting. So it's interesting because, we are kind of, and I personally, I was thinking a lot about LDL apheresis, and I realized that it's such a powerful intervention because not only is it lowering lipoprotein little a, although granted people unfortunately need to get these sessions on a recurrent basis, but it also removing a lot of the inflammatory factors from the circulation, which is not likely what the medications will do, right? The medications will not remove inflammatory factors. Inflammatory factors, inflammation, especially cardiometabolic dysfunction or so-called, cardiokidney CKM dysfunction. This is more within the lifestyle interventions. A lot of the times, this is kind of what we emphasize in our approach with patients. So I feel like even with the advent of the medications, maybe it will just lower people's frequency of LDL apheresis, but if they have aggressive disease and multiple vascular beds, that's an opportunity for them for stabilization and potentially even reversal. So it is absolutely, a fascinating topic. You mentioned something maybe in closing, a couple of things. So maybe just, to give our listeners an understanding. So what are the resources that people can access? How can they connect with LDL apheresis center if they feel they need to come for a consult? Basically, how can they come and get evaluated for this? Are there any, foundations or nonprofits that you can mention where people can go to get more information?
Okay. So before we, get to logistics, I think you made a tremendous point, and people need to understand it. With lipoprotein apheresis, you're also removing C-reactive protein, interleukin-6. These are inflammatory markers. Fibrinogen drops down. The blood viscosity, the thickness of the blood changes. So a tremendous number of markers change in a favorable, fashion just with the treatment. So just not, filtering cholesterol. So I think that's a great point. And when you understand the mechanism of how lipoprotein A causes trouble, which is really, it has oxidized phospholipids on the surface. So these, pointed molecules that are sticking out cause tremendous inflammation. That's how they contribute to stenosis of the aortic valve. There's a lot of inflammation in that area. And of course, as I said, in terms of vascular disease, they are molecules similar to plasminogen, which, breaks up clot and by being similar and blocking the pathway, it becomes prothrombotic.
Right.
So it contributes to, thrombus formation. And then, at a vascular level, it promotes smooth muscle cell proliferation and more local inflammation and more foaming macrophages and adhesion molecules. So, lipoprotein A is not not a nice molecule to have, and certainly in volume.
Like I said, small lipoprotein, big trouble.
That's it. You should actually make that into a T-shirt. I think.
I think that's going to be the title of this episode: How Little A Causes Big Problems.
Exactly. So that we got more than that. So, in terms of, for the patients, it's very important. There's a foundation called the Family Heart Foundation, and they have, information on lipoprotein A and on familial hypercholesterolemia. They also have, what lipoprotein apheresis is, and they have centers throughout the 50 states that are highlighted there. So I think that's a great, resource for patients. In terms of our apheresis center, I get calls from people from Connecticut, the 5 boroughs, the Hamptons, wherever they are, because again, we're only talking about 2 centers in New York, and not everyone is an apheresis candidate. But the important thing is they're a candidate to be treated, and they're a candidate to have risk factor, improvement. And that's an opportunity to help. So it's not for the doc or the patient to know who needs to be an apheresis candidate, but at least they've measured an LPA, for instance, and they know who's a higher risk patient. So I think, for the patients, start with the Family Heart Foundation. I think it's also a good resource for clinicians as well. I think the National Lipid Association, they have a updated statement on lipoprotein A, and says, the American Heart Association as well. So I think tremendous number of resources out there. And we've come a long way from 15 years ago, where the New York Times said, we don't know what LPA is, and, kind of put the docs under the bus over there. So I think our challenge for what Dr. Druz does and what I do is just to get the message out that, patients can ask for the blood tests for lipoprotein A, and you're going to hear more about it as these medications become closer to, utility for us. But just ask your doctor to add a lipoprotein A onto it. And then some doctors will say, why should I? Because there's nothing to do about it anyway. And then you can think about your doctor at that moment. But there's a lot to do about it, because, again, if you're walking down a dark alley and someone's going to shoot you in the chest and someone's going to stab you in the back, you want to neutralize both threats. So it's not just the LDL, it's the entire picture. So,
and I think you're being very generous for LDL with regard to risk reduction, because you said there is a 50% risk reduction with LDL lowering. If you read Peter Libby's stuff across multiple trials, it's actually only 30%. So the residual risk is sort of like, I always have a problem with calling it residual, because how can 70% be a residual? It just defies all sorts of, typical math definitions of what residual actually is. So you're being very nice, very, very generous toward LDL reduction.
Well, that's a good point, but it's I said up to 50%, but the reality is you are right. And it's hard for patients. If I say 34%, well, what does that leave me left? Is that 64% and 66%? And so if I say 50, up to 50%, people could figure out, oh, there's another 50 left.
There's another 50. That's not bad. I may repurpose this trick. That's
and the key word is how you deliver it. If you say up to, and again, the Jupiter trial, which is a primary prevention study, that a 54% reduction in first MI by manipulating C-reactive protein. And, I want to also tell something, else to your audience. When Dr. Druz and I say residual risk, that doesn't mean LDL cholesterol risk and then LPA risk. We don't have all the answers. Then we could talk about inflammatory risk, and there's a whole bunch of inflammatory molecules as well. But we can look at a C-reactive protein. Studies have shown us that reducing inflammation without affecting LDL can reduce clinical events 15%. So it's kind of like you're adding to the picture, to get zero risk. So residual risk is an important term to be familiar with. And just don't be satisfied that your LDL is fixed. And don't be satisfied that your LPA is reasonable, because the rest is still unwritten. I think that was a song.
I think, Guy, this is such a great point, is that I find patients sometimes experience sort of a tunnel vision syndrome, right? They're so focused on, let's say, LDL cholesterol or ApoB. Let's sort of like, most of patients already know that ApoB is a better predictor, at least in a population level, of cardiovascular events. But LDL-C is a reasonable surrogate, and that's what's been studied in the trials. But the thing is that most patients are very focused on lowering LDL cholesterol, lowering ApoB, and they're sort of missing the big picture. They're missing an understanding what is the composite of their vascular risk. And this is what you and I do, right? We really try to say, this is what this person's vascular risk actually is. Because I had seen plenty of patients, as I assume you have, who have perfect LDL and ApoB, and even perfect lipoprotein (a). They're not genetic carriers, nothing is elevated, and they had a heart attack and they had coronary disease because inflammation, oxidative stress, vascular immune response are absolutely engaged. And so we're just scratching the surface with the lipids and even lipoprotein (a) measurements. But the good thing is that we have now tools that could help us help our patients. So, this global risk assessment, personalized, is what we do in each of our initial encounters, so that each person has a roadmap and they understand what their options are. And as you mentioned, sometimes those options are a drug, or sometimes those options are, lipoprotein (a) or LDL apheresis. These are all available options, and we want everyone to make a decision that is most aligned with their level of risk and their tolerance of different interventions. So this has been a delight. Any last minute, impact statements to our listeners? What is it that you want them to do?
Well, I think one is to be an educated consumer. People spend more time researching a car to buy than, looking at their lipid profile and their longevity ability. So I think research the lipid panel and cardiovascular risk as well as you'd research a new car. Mm-hmm. You don't need to haggle with your doctor over the cost. All you need to do is haggle over doing the LPA and the lipoprotein B. To add to risk, I think Dr. Druz makes some important statements too, is taking it up to the next level, whether you're going to look for, polygenic risk and as we say, some genetic testing. But I also, the Dr. Samikas did a study, and also I think Dr. Borgensen in Europe, looking at LPA and also looking at ApoB LDLs, and they showed pound for pound, if you're a boxer, pound per pound, LPA is 6 times as atherogenic as the LDL. So, why is that? Because in a nutshell, it's inflammatory. It promotes changes in the vascular tree. So having it, is not something that should be taken so lightly. So I think, in summary, as I said, you need to be an educated consumer about your health. You need to be a partner with your physician. And again, prevention is what we do. I give the lecture all the time: prevent the event, and plaque attack. That's kind of
plaque attack. I
what
like
we
that.
do. So
plaque attack.
That's correct. And happy to be available to anyone with any questions. And as I said, we all collaborate with everybody's primary care physician and cardiologist, and there are tools for treatment. So it's not like there's nothing to be offered. And I think it's just look at the entire package.
Excellent. Yeah, well, thank you. And you've been a tremendous resource for me and a delightful guest. I just want to mention to our listeners that Dr. Guy and myself mentioned a couple of studies. So we actually just launched the Holistic Heartbeat, which is our newsletter. And what we do, it comes out once a month. And what we do there is that we provide an audio summary in kind of sort of more simpler language for anyone to listen to of these important studies, so that you can actually understand what was studied and what were the findings without having to read, this very long, medical paper. And for our professional subscribers, we of course give them access to the medical paper itself. If you have any questions for myself or Dr. Mintz, the best way to submit them is to become a member of our Holistic Heart University community. We have this patient Q&A feature where you can send your questions in, your comments in, and we will go ahead and answer them. If you're watching this on YouTube or any other platform, send in your comments and we will respond. Guy, thank you so much for being a guest. It was delightful and nice info on Lp(a).
Take care. Thank you.
Hi to all professionals listening to us today. If you're thinking of launching a cardiometabolic or integrative cardiology program in your practice, we can help. At the Holistic Heart Centers, we help docs in practice to expand into hybrid or concierge services. Head out to the show notes and click on the application link. Your intro call is entirely free. Ready to schedule a practice review? Use code DOC10 for 10% off our Practice Power Hour 16 minutes coaching session. The link is in the show notes. Thank you for tuning in to Own Your Heart Health with Dr. Regina Druz. This podcast is powered by Holistic Heart Centers. If you enjoyed the show, please rate and review us on your favorite podcast platform. To learn more about our services, visit holisticheartcenters.com and subscribe to our YouTube channel. The link is in the show notes. See you next week.